assume, or I hope everybody can see what's titled Clopidogrel 2C19 in the neurovascular setting.
Looks good.
Wonderful. Thank you. Thanks, Alyssa. So boy, putting on my professor hat, I put way too much stuff in this, too much content in this. And as we were going, as Sam and I were discussing this case, which is really an interesting learning case, some about pharmacogenomics, some about clopidogrel and its activation, and perhaps even its just the overall effect that it has on platelet aggregation, or in some cases over platelet aggregation. We decided to, well, I thought she's pretty much she'll be done here in 2 weeks with our PGY2. So I'll pull her in for certain elements, especially focusing on the neurovascular content. But I wanted to start with, because I know not everybody's at the same page, same place. Just a real quick overview of what clopidogrel and the interaction with CYP2C19 looks like. For some of us, this is an interaction that we're very familiar with, others not so much, but the gist of it is that clopidogrel requires activation for the drug to work. So in its base form, it's a prodrug, and so until it's primarily activated by CYP2C19 and a little bit to a lesser extent by 2B6. Those two enzymes, but again, predominantly CYP2C19. Without that, the drug doesn't work. And so there have been many studies, and I'll show you one very briefly here in a moment. But without that activation, the drug doesn't work, both on a pharmacokinetic level and an outcomes level. So the 2C19 has a number of known functional variants, or not known variants, I should say, that do affect the function of the enzyme itself. If you see it designated as star 1, that means it's essentially the functional or active variant. Or at least the wild type. The star 2, star 3, and a handful of others are responsible for elimination of the function of that particular allele. So if you see it designated star 2, star 3, or others, usually those are associated with no function. And then there's an increased function, star 17, that's a promoter variant that causes increased transcription and leads to increased metabolism. And so you see the range of phenotypes across the bottom, ranging from poor metabolizer to ultra rapid metabolizer on the, I guess it would be the right. And so we have a full range of phenotypes available for this drug with the different variants. Now, when we talk about clopidogrel, and this is relevant to the case that we'll get ahead, clopidogrel in the use for a number of different areas, but as an antiplatelet has a number of indications. Predominantly was originally used in the ACS space, specifically most of the data that we have for clopidogrel is with in the PCI area. So it'll be used after intervention. And so acute coronary syndromes, a number of studies looked at comparisons of clopidogrel compared to the newer drugs that had subsequently come on the market. Triton 38 was looked at prasugrel, showed prasugrel was superior to clopidogrel. Plato trial showed that clopidogrel was much more preferable or better, much better outcomes than clopidogrel. And so up until recently, a couple of years ago, there weren't really studies that compared prasugrel directly versus ticagrelor. Turns out the ISAR-5 REACT trial showed that prasugrel was actually superior to ticagrelor. So it's a fun little study if you're interested, because it kind of bucked the common knowledge or the common wisdom of ticagrelor, prasugrel, clopidogrel in that order of efficacy. So in the stroke TIA space for clopidogrel, up until recently, there weren't any really large trials. The Prince trial looked at clopidogrel and found it was equivocal in terms of outcomes with ticagrelor in terms of its ability to prevent stroke risk. So clopidogrel, ticagrelor are generally considered both acceptable options for stroke and TIA. The point at the bottom, prasugrel, because of its association with increased risk for conversion to hemorrhagic stroke in the setting of TIA and stroke is not recommended, or is actually contraindicated. And there's a whole bunch of other clinical considerations. Clopidogrel has generally less bleeding. It's of course less effective in most cases. Prasugrel and ticagrelor are not affected by 2C19, or at least not in a meaningful outcome way. And then clopidogrel and prasugrel are available as generic. So there's generic, excuse me. So there are genetic effects, there are cost effects, there are different side effects, all things that we have to consider with these. One of the earliest pharmacogenetics trials with clopidogrel was the study by Jessica Mega and colleagues, 2009. And so it was a cohort association study that they took data from, or patient samples from, the Triton-TIMI 38 trial. Approximately 1,500 subjects all received clopidogrel 75, and they eventually found that CYP2C19 was the key enzyme that was really responsible for the loss of function. Or the decreased outcomes, rather, with clopidogrel. And so in this study, they looked at outcomes. The primary outcome was this what are known as MACE events, major cardiovascular events. And in this trial, they looked at a composite of cardiovascular death, MI, and stroke. And kind of one of the classic figures that's often shown is what's on the screen here. And there's this great divergence in outcomes in individuals that are the top red line carriers of a loss of function allele for CYP2C19, meaning the drug, the enzyme's not working as well, so the drug doesn't activate as well. And so you see, as a primary outcome of cardiovascular death, stroke, and MI, these individuals do worse, to the tune of about 50% worse, 8 versus 12% after roughly a year. So this was a statistically significant outcome, and really the take home out of this was, gosh, hey, we have a single loss of function allele that can cause this drug not to work, or not to have as good of clinical outcomes. Boy, we should be finding some alternatives. Subsequently, there have been a number of trials, a number of prospective, non-randomized, like the IGNITE trial. Popular Genetics and Taylor PCI were both open-label randomized trials, that in very large trials looking at genotype-guided versus conventional or standard treatment, depending on the study. They found varying results, but not as overwhelmingly positive as one would expect. And this was in the cardiovascular space, so not the neurovascular space, but the cardiovascular space. And so, it's still the CPIC guidelines that have come out most recently, looked at this data and said, well, okay, yes, still the benefit is still overwhelmingly positive. It shows a consistent correlation between a loss of function in the CYP2C19 gene and the outcome. It will continue, stay the course. Needless to say, you look at the range of phenotypes, and I don't know if you can see my, let's see if we can get a laser pointer on here. The normal metabolizers, you would expect that the strength of evidence are going to be strong. That's where the majority of the population is living. But these intermediate and poor metabolizers have decreased metabolite formation, increased risk for cardiovascular, neurovascular events, and therefore, pick something else is the take home, something that's not clopidogrel. And so prasugrel would be contraindicated in the neurovascular space, history of stroke or TIA. But choose an alternative that's appropriate. And so strength of evidence for the cardiovascular space, because of these recent randomized clinical trials, because of the prospective but not randomized trials that were in the past, all strong evidence, but we lack a whole lot of we lack as great of evidence in the neurovascular, the stroke TIA space as we do in the cardiovascular space. And so with that, I'm transitioning here over to Sam. So Dr. Sam Freer is our resident PGY2, and in her last couple weeks, honestly. And so wanted to give her the floor and allow her to speak to some of this data in the neurovascular space.
Yeah, so thank you for giving that background on a lot of the cardiovascular information. And so as Jordan said, I'm going to be presenting now some of that information that the CPIC guidelines have utilized for those neurovascular indications. So starting first with this article by Pan and colleagues, which was a meta-analysis and systematic review. exploring that data of those CYP2C19 variants that were associated with acute ischemic stroke and TIA. And so as we just saw, the clopidogrel has been associated with a lot of inter-individual variability with response. And so now looking at it specifically in this stroke indication, they aim to assess the association between those genetic polymorphisms in CYP2C19 and clopidogrel efficacy for the ischemic stroke or TIA. And so what they did for this, which was a comprehensive search, they looked at PubMed and Embase to identify studies that would describe that association between those genetic polymorphisms and the stroke events, as well as bleeding. So for that primary outcome, looking at any occurrence of new stroke, whether that be ischemic or hemorrhagic, and then secondary endpoints looking at composite of stroke, MI, and vascular death, and safety, trying to determine if there's any difference with that bleeding association as well. And so then if you want to go to the next slide, overall, looking at a total of 15 studies there. So around 5,000 patients, and really just demonstrating similar findings to the data that we would expect, that based off of that cardiovascular data, that we would have these patients with a loss of function 2C19. So those alleles of 2, 3, and 8 having that increased risk of stroke in comparison to our non-carriers, which was found to be statistically significant. And then in the composite for the vascular events, so there was more frequent events in those carriers of the 2C19 loss of function versus our non-carriers, which was also statistically significant, but no statistically significant difference in our bleeding rates between the carriers and the non-carriers. And then this data here is just demonstrating all of those studies that went into the primary efficacy outcome there of the stroke, pointing out specifically this CHANCE 2016, the very first study listed there, showing that it had a high weight within this study, making up about a little over 30% of the data here. One thing to point out, though, is they did take that data out. They did do an analysis where they took that data out and still found that effect size to be statistically significant. So overall here showing that shift towards the right there of having that higher risk of stroke and that effect size, nearly a risk ratio of 2, that 1.92 there. And then, so overall, in this meta-analysis, we saw that those carriers of the 2C19 loss of function alleles are at a greater risk of stroke and composite vascular events than the non-carriers among patients with the ischemic stroke or TIA and being treated with clopidogrel, but no difference with those with the bleeding risk. And so the next article here is the CHANCE 2 study by Wang and colleagues. So this study here, basically extrapolating a lot of that information from that Prince trial that Jordan alluded to, suggesting that, that combination of ticagrelor and aspirin may result in a lower risk of subsequent stroke than the combination of clopidogrel and aspirin among those patients with stroke and the 2C19 loss of function. And so therefore this study, the CHANCE 2, was then designed to test that hypothesis that the dual treatment with ticagrelor and aspirin would be superior to clopidogrel and aspirin in reducing the risk of subsequent stroke among patients with minor ischemic stroke or high-risk TIA who were those 2C19 loss of function allele carriers. And so this was randomized, double-blind, placebo-controlled trial in Nature. And they received, for their intervention, either the ticagrelor or the loading dose, followed by regular maintenance dosing, or the clopidogrel followed by the maintenance dosing as well there, with both of them receiving aspirin daily. And for the primary efficacy outcome, looking at that new ischemic or hemorrhagic stroke within 90 days. And then for safety, looking at the bleeding according to that Gusto criteria. And so this is showing the primary efficacy outcome here of that new ischemic or hemorrhagic stroke within 90 days. And you can see the incidence on that y-axis and then Jason's randomization on the x-axis there. And so the curve is representing that cumulative hazard of stroke. And you can see how it's diverging during that first week there, or maybe a little slightly later. And then suggesting, that benefit and of the ticagrelor over that clopidogrel in those loss of function carriers is really happening very soon after that stroke. So again, showing that we have that reduced with a reduced incidence of the stroke with a ticagrelor and aspirin. And then for the safety outcome, no difference in that bleeding according to the Augusto criteria. And then another notable outcome from this study was that the death, which was a secondary safety outcome, was also found to be twice as common in that clopidogrel group. And so looking at these two studies, the big main takeaways that we should gather from that is our intermediates and poors of 2C19 are having that decreased clopidogrel activation. And so they're having increased risk of composite cardiovascular risk in that loss of function carriers. And we're seeing very similar outcomes. We might not have as much strong and compelling data that we do have in our cardiovascular space, but really trending in that similar direction as our cardiovascular space of showing those increased risk of stroke with our loss of function carriers utilizing clopidogrel. And also keeping in mind that, pharmacogenomics is telling us a portion of the picture. It's adding to our clinical decision-making process, not eliminating it. So we are having to still weigh a lot of those considerations as well that Jordan spoke to at the beginning of the presentation with our cost considerations and patient-specific factors.
All right, so I'm going to jump back in here very briefly because that's like the I don't know, the bulk of the content that we wanted to cover, at least in terms of the data. But I wanted to add some bonus content, if you call it that, if you'll humor me just a little bit. And I didn't feel that bonus content, it felt like it needed some like circusy kind of intervention or introduction, excuse me. So just because it's Friday. So anyway, I'm just livening it up just a little bit. With that in mind, because this case has some comparisons with different testing models, so we have the pharmacogenetics testing that we're gonna show you, but it also has on the side of it commonly platelet reactivity testing is commonly done. So I guess that would be considered a phenotyping type test. Because that is used in this case, I thought I'd throw you just a little bit of information, not necessarily about what the test is. I think we can understand the concept if you're not familiar with it, but more interested in, well, do these things correlate amongst these studies? Like, should we normally see the phenotyping platelet reactivity tests match the genotyping tests? And so, as it turns out, they've done a look at this study, and I'll just show you a couple brief slides, and then we'll move on to a case. And so, in the background of this study, done a short time ago, they looked at a number of, I should say that their aim was to really determine whether exactly that question I was setting up. Do these things correlate between genotype and these various assays? And they looked at 3 different assays listed on the screen there. The one I'm focused in on is the Verify Now study, test, because that's the platelet reactivity test that we use at our institution. And so they looked at 83 individuals, so a fairly small study, but enough to get some compelling data. Included mostly adults following ACS in this case, or non-ST elevation MIs, or unstable angina. So they were all individuals that had, it's all focused on the cardiovascular space. So, but since we're focused in on the activation of the drug, felt we'd include it. So a number of exclusion criteria. not hugely pertinent, just really focusing the data in on the most important, can we identify the effect? And so, so the results specifically to the Verify Now assay, when we look at it, the platelet reactivity units are the figure on the left, and that shows an extensive metabolizer, a normal metabolizer, which you would expect or should usually see a lower number in these cases. So for their test, they expect normal range should be in the 194 to approximately mid 200s. So 190s to 200s, that would be the normal platelet reactivity that you'd see. And so if you're adding clopidogrel in a normal metabolizer, it's activating the drug, you should see that platelet reactivity drop. Intermediates show a little less effect, and poor metabolizers are actually in a range. In fact, both the IMs are fringing on the normal range, and the poor metabolizers show right in the dead center. So they're not activating the drug sufficiently. And so proportion to platelets with residual platelet reactivity, extensives almost none, so the drug's working like it's expected to. Intermediates approximately 20%, the poors are almost 60%. And so you see at least the effect between normals and poors are statistically significant in both cases. But the comparisons, intermediate comparisons, are not. Over here in platelet reactivity are. So that's the gist of this. This was also repeated in the CHANCE-2 trial, and they showed similar data that replicated this trend as well. So this is an older study, not related in any way, but they saw the exact same effect show up in the CHANCE-2 trial. So what we do see a significant association. What we should normally see would be CYP2C19 genotypes are associated with changes in these platelet reactivity. It just makes sense, and that translates through study after study after study. So with that, I'm going to stop with content